got the Oura Ring on. I've got a continuous glucose monitor that my wife orders. I've got an EKG 30-day monitor on. So you guys got me as the lab rat of the week since I had a weird syncopal episode. So I'm the hospital at home. Every time you play fantasy football, pick your player, right? For me, Joe Burrow is supposed to get 26.75 points. They don't just guess that. On EA Sports, they run that simulation 100,000 times with his person in a video game to give you that score. 5 years from now, 8 years from now, we'll be doing that with all of our health data. So the rings that you're wearing, David, you will have that baseline. And it's not that far away. This isn't science fiction anymore, guys. This is actually arriving soon.
We're going to get to the personalized medicine with the predictions exactly as you described. I'm super excited about that. Welcome to AI in Healthcare. My name is Dr. Sanjay Juneja. I'm a hematologist and medical oncologist, also known as the OncDoc on social media. And I am joined with some familiar faces, Dr. Douglas Flora, who is the chief editor of the AI in Precision Oncology Journal, peer-reviewed. You've got to get into it if you're interested in AI at all. We also have David Penberthy, who is a radiation oncologist, has been a program director of both like residency as well as radiation programs. And we are joined with our very good friend, Sam Barend, who is the CEO of AION and really is passionate about wearable technology because her father, which we'll get into, had a diagnosis that made him much more susceptible to infection. And she has a firsthand example and realization on how much infection and tracking things outside of the clinic affects the livelihood of both patients and families. And all of that to say, that's what we're going to talk about today. It's going to be wearable technology. Some people call it, continuous, patient monitoring or remote patient monitoring, but the concept is the same. And that is this concept of continuous longitudinal data, meaning all the stuff that occurs outside of those snapshots in your clinic that ultimately people hope and believe can cue us that, before we have a heart attack or before we start having permanent neuropathy from chemotherapy and all these other things that we're trying to catch. That's the concept that we're going to discuss today. And it's a very interesting one because it has legal aspects, it has regulation aspects, and it, of course, has implications for both patients and providers. So with all of that said, very excited to have you all. And Sam, specifically, I'm going to start with you. You must be super excited just about this entire concept in technology today, right?
I'm excited to be here with It's an honor to be here with all of you. I'm excited because we're at a pivotal moment, thanks to the thought leadership that you're all bringing forward and making AI such a centerpiece in healthcare, but most importantly in oncology, because it's not been at the forefront. And so I think, where we come from with AION Biosystems, with our AION Temp Shield, is that many have thought about wearables as wellness tools, and we are bringing Temp Shield forward as a survival tool in oncology, and in a single one signal that has a low amount of noise around it and the opportunity to so dramatically transform outcomes.
And when you say wellness tool, I think that's very interesting. David, if you would, as a wearable kind of expert, tell us, the difference between these wellness things that everyone's familiar with and really how that translates to, CPT codes and FDA regulation. Because I'll be honest, I was pretty shocked. I know you love the Oura Ring, that it is not, technology that the FDA has on their list. There's a special list where they have sensory devices that you can look up to see what's been kind of vetted. What's the difference there, David, and how do you see them in your mind?
Think about it like this. We all have the check engine lights on our cars from years ago. And so what happened with that check engine light? We were like, what the heck is going on? We had no idea, right? So right now, we're in the very early stages of this whole wearable kind of transformation within healthcare. I gave a talk a little while ago, a few years ago, actually, and I was joking with people saying that momentarily we're going to have ICU level monitoring on our bodies at all times. And slowly and surely, it's coming true. And so just like our cars now have, tire pressure monitoring system, they have oxygen sensors, they have all this kind of stuff. We are starting to do that in our own lives. And we're trying to figure out how to integrate it into the healthcare system. I had a really interesting discussion. I have so many stories to share, and I'll share one just real briefly. at an unusual place in the U.S. Embassy in Riyadh, Saudi Arabia. I met another person wearing this ring. And so we kind of like joked about it, saying, what do you use it for? Do you use it for sleep tracking? Use it for activity tracking? And he said, I'm not doing it for me now. I'm doing it for me 15 years from now, because one of these tech companies is going to use the data in very interesting ways to maintain our health and give us a non-intuitive insights. And I think that's what we're starting to see. Right now, we're just scratching the surface on what is possible. But you asked a couple of really good questions, and I may actually parlay this to Sam just about the FDA approval process and what's the difference between an FDA device and a consumer device in this space.
Before we do that, I want to know too, I want to hear from Doug, because one thing that we all hear about are the kind of things that we don't have data for necessarily, right? So it's like we have the sleep cycle. Okay, awesome. We have the things that have to do with exercise and caloric burn. Okay, awesome. But then when you're really talking about things that are predictive, and of course, David, as you said, almost kind of doing a good deed for our future self. Because if you don't have data on yourself today, then you can't benefit from these things that really crunch these numbers and are continuing to do so when these algorithms come out. Doug, what is your experience, and what have you heard from your patient population and your colleagues on what the concept is behind it, outside of the kind of medical aspect when it comes to just everyday living?
Yeah. Well, I'm with David. I got the R ring on. I've got a continuous glucose monitor that my wife orders. I've got an EKG 30-day monitor on. So you guys got me as the lab rat of the week, since I had a weird syncope episode. So I'm the hospital at home in my office today. I would say, Sanjay, to speak to your point, we've always had this sort of shared decision making in our offices where patient reports how they feel, doctor sort of interprets it as this mystic sort of religious figure that is supposed to demystify things based upon what's reported. And I feel like now with these tools, the Aura and other, I can share data with my doctor that really talks about, like, here's the game replay. Here's what we've done together over the last week. And he can say, or she can say, look, you had a dip in your blood sugar right before you got dizzy, or wow, 3 days before you started to show signs of COVID, your heart rate increased. And I love the idea that instead of just saying your labs and vitals look okay today, it's like, hey, your activity shifted after chemo 4 days after. Here's the day your symptoms spiked. What was happening in your life then? And I really like having that data as the clinician and as the patient.
Absolutely. And to that point, over 100 million Americans with chronic conditions, I'm told, use RPM or remote patient monitoring systems. I'm sure a lot of those being diabetes, nearly 30% of that population. So Sam, break it down for us. Where does this where does this world live that goes from consumer stuff and wellness stuff to all of a sudden being, something that's utilized and also potentially either billable or coded or medically sound, all the legal stuff. What helps us cross that line? Because that was a whopping number when I read that 30% of the U.S. population already having remote monitoring.
And what they did in CGM, and why CGM is this is a big part of the reason why so many patients are doing remote patient monitoring, is because they cracked the code. What they did that was so successful is they kept it simple. They didn't boil the ocean. They made it simple for patients to wear. They made it simple for doctors to implement. They made it simple that patients could monitor themselves. Doctors could monitor them if they wanted. They could get the data. There wasn't this liability overload. And that's why it's skyrocketed. And that's pretty much similar to what we're doing with TempShield. We're trying to show, just like they did in for diabetics, that you could take one very strong signal, in this case, your blood sugar level. In our case, in oncology, it's temperature, long-term temperature tracking. With high precision, you can dramatically transform outcomes. The temperature is the same type of impact signal that blood glucose is for diabetics, if measured over a very long period. And so we've been able to, unlike most of the wearables, gather the reimbursement data that they have not been able to gather because we have such strong adherence. Patients are generally wearing the TempShield device for 120 to 180 days. So we're getting the CPT codes, the 99454, 99457, all the monitoring codes and the education codes. So we've shown in our clinical study that 99% of the patients were reimbursed, which is a big milestone.
And that's where I'm going. That's where I think is so important, because that's what's impressive is, all of the stuff on a tech aspect is super cool or impressive or just techie, for lack of a better word. But can you tell us, what are they looking for, to qualify for something to be reimbursable? Like, especially when it comes to 510K, I've heard that before. I've heard FDA approved versus FDA something in between. What is that? Are they looking to ensure that there's efficacy, or are they just making sure it works outside of efficacy and efficacy not necessarily relevant? What does that process look like? And what can patients and Americans say, okay, aha, this has a 510K approval, or this has some kind of FDA approval? That means X. What is that
Yes,
X,
so
so that
that
we can kind of have that
okay,
placation?
so this is great because especially in oncology, medical device is very new, especially in this realm. It's been around forever in cardiology and so forth, but not in oncology. So 510K clearance means that the device is approved to be used. You can have over-the-counter approval, and then you have a prescription approval. We have both. Can be used as a prescription order by the physician in the clinical setting, and it can also be available for over-the-counter. But in order to do this, attain this 510K clearance, typically you have to have a predicate device that you are following, and that there's something else in the market that you're modeling yourself after, and that will serve as the predicate. In our case, we had to use the Welch-Allyn oral thermometer as a benchmark. This is what we're validating our device against. We're going to be as good as the medically grade Welch-Allyn oral thermometer. And basically, they make you go through a lot of validations and to show that you're as good, you have to do it in a clinical setting, you have to do it on large populations and so forth. And then you have to do it with different age groups as well. We're validated for children 1 and up. So we had to show in the different age groups that we were good enough. But I'll make the case, just because a device is validated, FDA cleared, doesn't mean it's good enough to be serving your patients, because we've seen this. You've seen a lot of noise. We have to struggle with it, with some other devices that are in the market that are giving false positives and so forth, because even an oral thermometer isn't the traditional. There's many cases of oral thermometers. So what we've had to work very hard. We've been in the oncology sector for 2 years and working to get rid of the noise, be very laser focused so it's good enough in oncology. And so while the FDA does a good job in making sure the device is safe and suitable, has benchmarks, in order to meet these high standards, especially where we're all going in this AI world, that we demand the best, the most precise care, the bar, I think, is even higher than the FDA clearance.
Interesting. So when we see these things that are coming out for oxygen saturation or temperature, or glucose levels, it's, because there are things to measure it against, so that you can say, okay, this is, this was the way that we're doing it. This is the accuracy of this continuous monitoring that goes in addition or with that. But it does not necessarily mean that the utility or use case is there for, a benefit one way or the other. Doug, I'd love to hear, Doug or David, what are some of the things on the physician side, because I know you all get pitched as thought leaders all the time on technology stuff and wearable stuff. What are some of the things that are going through your mind as far as, okay, I get that it's valid and legitimate, or accurate for what it's supposed to do. What is part of the decision making when it comes to, is this something that's of utility, especially if it's going to cost anyone anything outside of being fully covered?
So, Doug, I'll start with this, then you can add on or correct me. So I've been doing this long enough that patients used to come to the office with spreadsheets of their blood pressures and spreadsheets of their temperature. And we didn't really know what to do with that, right? Usually people would come in for episodic care. And if somebody gets admitted to the hospital, maybe they're getting vital signs every 4 hours or something like that. Now we're getting information that's continuous. And it's the richness of the information is something that we're all trying to contend with. One thing that I'm super impressed with the Temp Shield, though, is with the patterns of temperature variations and fluctuations, they're not only diagnosing or pointing to infections, but they're pointing to specific types of infections. pneumonia has kind of a different pattern than urosepsis. And so that to me is where we're going to get non-intuitive insights when we allow the AI to kind of work with these systems and kind of correlate what's happening. And again, we are at the very early stages of this. And so right now, I would say it's helpful for patients if they're at risk of falling. It's helpful for patients, if they're concerned about their temperatures. We're not importing all the information into the medical record just yet, but I think that's coming.
That is one of my concerns, is this whole concept of interoperability, because we know interoperability is tricky enough as it is just to get the stuff from specialists that, may be involved in your patient's care. And in our clinic down in Baton Rouge, we have our GI is a different place than our thoracic surgeon, and they're all in different EMRs. So the interoperability aspect of just the data, that's the one-time snapshot data, is rather challenging. So I'm very interested to hear, really, Doug, what do you think about this concept of is it something that now is going to have to live or die by its ability to be into Epic, for example? Or do you see a world where there's going to be these third-party apps, or is there a fourth party that's the third party to all of the devices that actually somehow translates it and then brings it back into the EMR systems? How do you see that kind of fitting into a workflow, being, the executive director of a very successful program at St. Elizabeth's? What do those challenges look like, and how do you see that actually, quote unquote, playing out?
I'd say for hospital systems, it's a bit tougher. That has to be integrated. It has to be integrated into the workflow, has to be integrated into EMR, has to be integrated with our navigation program. So that's a little heavier lift for a lot of companies like Sam's and others that are really wading into this. What I've told a lot of builders is start with the private practices where they don't have quite the bureaucracy. They don't have quite the 17 levels of committees and the compliance officers under every rock. And it's just tougher to get some of these things piloted in a healthcare system off trial. So I would say that the other difference, I think, from a consumer standpoint is, I could tell you, Dave and I, we talked about our rings. I love the data. So I think patients and consumers are going to drive a lot of this too. Maybe not the medical grade stuff that Sam and her company are working with, but man, I look at it the first thing every morning, compare my sleep score to my wife, and usually lose. I look at my heart rate variability. I look at my pulse ox, which never changes, but it's sort of gamified. So I'm into it. And I think that even if hospitals like mine don't get there quickly, like David said, the patients are coming with their data anyway. It's no longer like the engineer who comes with a graph of his wife's potassium for the last 6 weeks. She has the potassium values, and it's not the Excel spreadsheet. It's here, look on my phone. I've been tracking this, and so if the hospitals are late, the consumers are going to lead it.
I'll be honest, I'm a little ashamed to say this. So I'm saying this, with some embarrassment, but I have held off buying an Oura Ring this entire time. And this is why, because I was like, I work out as much as I can. Which isn't what I'd like it to be. I sleep as much as I can, which isn't what I'd like it to be. And if I was just more aware of what I'm not doing well, I'm like, it's only going to add another stressor to my life. Like that was arguably an ignorant, take on it. But this is why I wasn't doing it. Now, I was at Health a couple of weeks ago, and I had two people, and one was using Oura Ring all the time, and the other one was kind of similar to me. And they both said, we're very excited about postpartum related things, post menopause or perimenopause related symptoms, and pregnancies and pregnancy complications. And my comment was, well, if you don't have longitudinal continuous data at all, because they were sharing excitement about the day that stuff comes out, I'm like, it's going to be much more challenging for you to be able to plug in your data and to understand or appreciate what the algorithms may show as concerning or not concerning if you don't have retrospective data. And that kind of changed all three of our aspects, because we're like, wait a second, that's true. Even if there isn't something necessarily actionable today, if you believe that there are going to be insights that come out from this aggregate of study over time, then it helps to have a collection of data to then introduce that point solution, introduce that algorithm, and then be able to really tell, say, those, perimenopausal symptoms when you may have those insights, right? From REM cycles, while you're sleeping. If you're starting when you have perimenopausal symptoms, that's different than not being perimenopausal at all, and then having the Ring data that entire time. So I don't know if that makes sense, but it's important to know what your baseline is before you know there's a problem. Now, with that said, Sam, that's, part of the reason we wanted to have you on this podcast, because you took something as well described and primal, I would say, and I choose primal, on purpose, which is temperature regulation. I mean, this is not a foreign concept. And you had a firsthand experience with your dad when it comes to treatment for cancer, which is something that all of us are so well conditioned to know. We keep saying, please tell me if you have a temperature of 100.4 or greater, and then sometimes even that temperature is debated. But you were like, wait, why are we putting this in the hands of these spot checks really randomly on the competency of somebody at home or on the physician catching somebody at the right time? You're like, there has to be some tip-offs that actually are variated or differ between a bacterial infection even versus just perimenopausal, heat rising for all I know, or the chemos that knock out estrogen, or the treatments that knock out estrogen. There's so many things that can determine what a rise or a fall may be. And I think you just kind of realized, so we should know all of it, and we should know what ends up happening. And then we should start understanding what kind of changes, how fast, how slow, how rapid occur for these different principles. Because at the end of the day, these are very kind of core brainstem. Don't quote me on that, but they are more primitive brain neuroanatomically. And I think there's been success with that kind of concept, with what you created that for people like your father on being able to catch something maybe before somebody was hypotensive, because they might have had these fever patterns before they can't hold their blood pressure, despite constricting and tightening all those arteries to get to their brain.
That is, you said it. I don't know what else there is for me to say, but I'll say a couple of things. So it was eloquent. So it's essentially, when we started creating Temp Shield, it was COVID. We had initially thought about this for COVID patients, post-op patients, ironically. And my dad has leukemia, and in the midst of developing this device, he was nearly dead, had to be resuscitated. He was at Flagler Hospital with sepsis. I was told he had 2 weeks to live. I basically had to mobilize every relationship I had, move mountains, campaign, and get him transferred to Mayo Clinic in Jacksonville. And thank God Mayo Clinic saved his life. But not everyone gets a Mayo Clinic miracle. And at that moment, I realized, oh my God, we've been living in fear of infection. And 50% of cancer patients are dying from infections and complications. And it's even worse in hematology, where my dad, for her leukemia, it's, patients are ending clinical trials, not because of the drug not working, but because of the complications. They're not able to stay on the treatment long enough for it to work. And so I sort of realized, okay, we're going all in oncology. Forget everything else. It's only oncology. And we're going to figure out a way to keep patients alive long enough for these treatments to benefit, because not everybody, people, it shouldn't get to the point where it's a flame. If we can catch these issues when they're a spark, we can really make a difference. This was the thinking, but what did I know? I'm not a doctor. What did I know when we were developing? This was the vision. And so we were developing and realized how hard temperature is. We actually picked the hardest area to focus on. That's why you see so many heart rate devices, respiratory rate. It's all out there. It's everywhere. It's easy. You can get it very cheaply. Temperature is so hard because nobody had really figured out how to do it really well, because it's, they try under the armpit. It's very noisy under the uncomfortable. And so we were actually ready to get our FDA clearance, but realized we weren't good enough for cancer patients. So we waited another 6 to 8 months and did even more and more testing to be good enough. The thought was, we have to be good enough for a bone marrow transplant patient. We got our validation, and then we started at Roswell Park Cancer Center, and we didn't know what we were going to find. We had a couple leukemia patients that were involved in our FDA validation, but we really hadn't been on a lot of cancer patients. So we had no idea what we were going to find. Were they going to like it? Was it going to cause them anxiety? Were they even going to wear the device? And something special happened. We started saving a lot of lives. We started identifying urinary tract infections, pleural effusions, a whole gamut of complications very early. And we showed a 90% reduction in mortality over for patients that wore the device for 60 days or more. The average patient wore it for 120. And a 79% reduction in hospitalization. The patients who declined to wear Temp Shield in the control group, this was all in community oncology, the ones who died in that group all had sepsis. So we know that we made a big impact. The device is great, it's special technology, but the standard was very low. The bar was an oral thermometer. You take it, as you said, when you don't feel well. Many of these patients have neuropathy. They can barely take a temperature. The forehead thermometers don't work. And what we realized, to your point, Sanjay, was that you can have one spike in a day, and that spike, to David's point, is the check engine light. It's the early warning sign. And we initially thought maybe these were false alarms, but what we were realizing is they're not false alarms. These were early indicators. The body, at a very early point, 3 to 5 days before any issues, that trouble was brewing. And that if you can follow these warning signs, you can dramatically change outcomes. And that's what they did. They dug in. They found pleural effusions. They found lung abscess. They found thrombosis, skin infections. The list goes on. So we're excited about the future. We're excited about the impact. And from a workflow standpoint, starting to bring this in a more rapid place and scaling because of the simplicity.
You're describing a great use case for a population of people that really need to be carefully monitored. We're also using it for populations of people that are interested in wellness. And I'll give one example that's a slight cautionary tale that we had at our institution. We have over 850 residents, right? We're very concerned about resident wellness. And so we offered to residents, a tracking device so they could monitor their sleep and try to optimize their health. And to your point, Sanjay, some of them already knew they were getting as much sleep as they could, and they actually didn't want to be tracked, because if they were at work and they didn't have a great night's sleep the night before, would they be taken off shift? Would they not be allowed to do a surgery? And so it was actually not really well accepted by the residents. And so we have to be kind of cognizant of the potential pitfalls of these technologies and the populations of people that we're using them for. So, but also to Doug's point, I think it's going to be consumer driven. I think a lot of people will embrace this. We'll have some interesting data that we're going to collect and analyze in interesting ways.
I think the key, that I keep hearing is, can we catch something sooner? We always talk about that with cancer. Can we catch it sooner? Can we catch it before it metastasizes, et cetera? But when it comes to things that are truly debilitating or even result in mortality, I think a lot of us get excited about AI's ability to be able to kind of get that clue or tip earlier. And Sam, the way you very beautifully described the temperature dysregulation that may occur before something more serious, and you have these statistics, 79% reduced, hospitalizations. I think too about heart failure, because, right now it's kind of crazy that the way we tell people to tell us about heart failure is to get on a scale. And only when you have multiple pounds of weight difference, which, mind you, means you're already having, this third spacing or this capillary leakage of your fluid from your vasculature, because the impaired contractibility of the heart, because it's overextended. We're talking about a lot of things that happen before you start gaining pounds or kilos, for that matter. And there were researchers at Mass General Hospital that actually took a deep neural network and used a single lead EKG, the data from it, to be able to appreciate left atrial pressure increase. So meaning, people will often say, including cardiologists, so it's not just me, that it's just closed plumbing system, right? Like in the body. And that if something ends up going, backwards, and it expands because things get kind of regurgitated. And they were trying to measure or appreciate this distension, which is one of the first things that's going to happen before all of the weight gain and all of the things that, the large edema in the legs, et cetera, et cetera. So that's one example of really measuring something far before the downstream, no pun intended, effects. Another one that I think about, and Doug, I'd love to hear your opinion on this. We talk about monitoring for heart failure when we give certain chemos like anthracyclines. We tell all of our breast cancer patients, hey, tell me if you start having, again, downstream problems, shortness of breath when you're walking, when you're laying down, which we know, you and I know, are quite severe and really not ideal. Like, those are scary at that point when you're having those symptoms, but it's the best we can do, right? Are there things that you get excited about when it comes to wearables that can actually clue us in, like this, this Mass General deep neural network processing, or others that you know of that may be able to measure or see these things happen before they have these downstream effects? And then you're not off the hook, David. I want to know, for you, when you're doing radiation, you worry about pneumonitis, which I know radiation doesn't want to say was ever the radiation, but you may have radiation pneumonitis. You may have radiation-induced bronchitis if it's a central lesion for an endobronchial tumor. First, Doug, what do you get excited about? And then David, on what do you think may be able to clue into those things sooner?
Well, it's cool that you're asking, because I mean, literally, you guys know this. I've got a 30-day event monitor on right now, and it seems so archaic that I have to press a button on my chest to capture an event, right? To me, what if I'm unconscious? What? So I don't know. So yes, there are a bunch of devices. Cardiology is well advanced in this. You know about CardioTag, right? The FDA clearance in August last year that looks at not just your EKG, but your PPG, your seismocardiogram, like the vibratory sense of your chest, to predict LVEF, to give you insights into ejection function time and those sorts of things. We talked about the ring with heart rate variability. As the fabrication, and our electrical engineer, flight surgeon David can talk about this, the technologies, the fabrication, these tools are getting so finite that it'll be fabrics soon, or tattoos soon, rather than devices that have to be stuck to the chest. I've got a sticky thing on right now, and it looks like about a USB port. It itches like crazy. I've got to take it in and out. I've got to charge it every night with this phone charging as well. I'm just really enthused about the idea that they're getting smaller and smaller. You saw Sam hold her device up, and as we get to this next generation of chips and AI pattern recognizers, it's pretty exciting to think that, to go back to David's analogy about the check engine light, we're not going to be pulling into that station with a car that's rattling or breaking down or pulled over on the side of the highway. Our pit crew is going to say, we saw something happen 5 minutes ago, and this is what we're going to do about it.
100%. David, tell me about possible radiation-induced, injury.
So, a couple of things. While people are actively receiving radiation, we have the benefit that we're seeing them every day. And so we're literally having person-to-person touch points, evaluations, and that sort of thing. So we can intervene if somebody has symptoms, describes something. We're not always checking somebody with x-rays or that sort of thing. So, but to Doug's point, with the miniaturization of all the technologies, it's becoming, sensors are becoming ubiquitous. And so they're going to be monitoring absolutely everything. And so we think we could do a better job of, identifying radiation pneumonitis. That's just one of many kind of inflammatory conditions that can occur with the result of a radiation treatment. Right now, radiation pneumonitis is sort of a diagnosis of exclusion. It has to be the timing correct and not another reason for it to be caused. And so we don't have a good way to use remote patient monitoring to specifically diagnose that. However, if somebody is wearing a spectrum of technology that points to the fact that their heart is maybe having some challenges, if their temperature is elevated or something, that can be an early indication to bring them back after they finished treatment for an early follow-up. And so we do think that these technologies will help stave off acute hospitalizations. And so I really think, to Doug's point about the hospital at home, that is happening as we speak. ICU monitoring level at home, we have to be concerned about alarm fatigue, because, if the brackets for normality are too narrow, people may start to ignore it. And we need to have a system that is robust enough that we pay attention when it indicates something is happening.
You said like diagnosis of exclusion, David, and that's what I think, would be nice, is to kind of almost make that term shrink, as well as kind of, I would say, like kind of deconfound the confounders. Because as Sam was able to do a temp shield, she was able to characterize potentially, like, is something coming from an effusion versus a viral versus, bacterial septicemia. Like, we have diagnosis of exclusion because radiographically they may look the same. But when you're able to take multimodal data, or this concept of multiomics, and say, okay, this is what we have in our radiomics, but if we have enough people climbing the same flight of stairs or making the same walk from where they parked their car into the clinic, and then start characterizing from the longitudinal data those that ended up having a bacterial pneumonia versus a radiation pneumonitis versus something that was possibly from an antibody drug conjugate, and you have enough of those, that could potentially tell us what the behavior of this shortness of breath is. Is it like, held off and then all of a sudden precipitous? Is it gradual? There are some certain characteristics that people get excited about, hopefully, to be able to get to the bottom of characterization, which have to do, again, with earlier and with patterns, which is nothing but, better suited arguably than AI, and less so the binary presence or absence of something. And one of you mentioned, looking at other things that may even go deeper. I'd love to know what y'all are excited about or what blows your mind, because when I found out that you're able to actually track, things that are longitudinal on effusions and in sweat. I've read that people actually track sweat for sensors to be able to even tell the biochemical things that may be happening inside the body, whether it's physiologic, autoimmune, or especially when it comes to treatment-related metabolism, as well as cancer, potential anti-cancer activities. You can actually, theoretically at least, assess the biochemical makeup of these fluids that are other things from potentially, like what a ring may show you, or a wearable device. So I get excited about that. And the second one that I get excited about, I think the FDA has a digital health center of excellence where they're trying to formalize the investigation of how this kind of new capture of data can be intertwined into our everyday medical practices, because it's a new data set or a new data point that's different, that you can actually start to assess, or people are looking at assessing neuropathy far earlier by having things that are in the soles of your shoes and realizing where you may put or prefer pressure points that you may have avoided before and are no longer avoiding them, how your walking patterns may be different, how we often assess in primary medicine for discrepant leg length, these kind of things that we would look at the erosion of the shoe to tell if somebody has an antalgic gait or again, length discrepancy. They're looking at that during the course of chemotherapy to see if a tip-off may be present sooner for a behavior far before you recognize it. Again, for me personally, when I hear wearables, I hear earlier tip-offs. Like, that is where, if I had to kind of categorize my excitement about wearable technology, is this whole concept of preventative versus reactive, which Sam, knows better than anybody exactly what she's doing. She's like, how can I find out before you're hypotensive in the ICU? How can I find out before a grade 3 or a grade 4 toxicity, which in cancer usually means that you could almost not potentially use this anymore, or you have to make some, significant change. If you can catch it in a grade 1 or grade 2 when it comes to an infection, or other causes of elevated temperatures, you're talking about salvaging medications because you were able to respond, more promptly. When I realized as an oncologist that some toxicities occur not because the drug is terrible, but because we found it late, right? That can equally contribute to someone's ability to be on immune therapy, for example. So I don't know, just so much that, we could talk about. And those are just some of the things I get excited about.
We are very excited about the opportunity to expand market access for these drugs, the bispecifics, CAR-T, but also the, like you said you were alluding to, like the ADCs and so forth that have had troubles in getting the clearance and enabling a whole new class of drugs, some of the most innovative treatments that aren't failing because of the science, but they're failing because the patients simply aren't strong enough to stay on them. And if we can keep the patients strong enough, get these complications early, it can be game-changing. For instance, in even bispecifics now, I was just talking to an oncologist from University of Miami, and he said, the problem right now in bispecifics and cellular therapy is that patients are being over-monitored in the first month, and then they're falling down and faltering months 2 and 3. And the problem is a lot of these drugs, they're not getting the full benefit of these drugs. With our device, it would be simple to, you can do the heavy duty monitoring when they're at the highest risk of CRS for month 1, but keep monitoring them. That you don't have to go from Rolls Royce to, the nothing basically. And our device allows the continuous protection. And so what really excites me, to your point, is that we can, I think that there's so much innovation right now in oncology. The care is at the top level that it's ever been. Now we just have to give patients more tools to be able to make it through, empower them to be strong enough.
Sam, you said it really well. And this is a tool that we're using and we're figuring out how to use. And Sanjay, you mentioned it as well. We need data. And once we have this tool that's out there, we're going to see like what the use cases are. And we need to make sure that it's applicable to everybody, right? Not everybody can afford these wearables that we are so fortunate to be wearing, but some societies are actually adopting it at rates faster than America right now. And I want to point to the Japanese right now, because they have all sorts of smart technology. They have smart bathrooms. And so talk about tools and information that you could use to diagnose things early before somebody's symptomatic. I mean, that's literally doing chemistries on, some waste products, not to be gross or indelicate, but, this is early stages of next level of care. And the next level of care is prevention. We're going to use these technologies in such ways to like help promote people's ongoing health as opposed to being reactively treating disease. Although we still need to treat disease as effectively, as safely, as cost efficiently as possible to give people the best chance to, for longevity. So I'm just super optimistic about what the future holds in this space. And I think momentarily we're all going to be using this. We're not going to be going to the doctor when we feel sick. We're going to be like having indicators that, you feel a tickle in your throat, something's going on. Now we're going to have a little bit more detail than just that. It's coming fast and furious.
Fast. And let me go one step further. And I'm going to ask you this, Doug, because you introduced this concept to me years ago now. Tell us about digital clones and how, when you're talking about preventative stuff, you can actually take this wearable technology and data, put it into, as I understand it, into something else to help your preventative measures, a step further. What do you see? One, that's very exciting about that kind of concept. Two, what do listeners not know about this concept? And three, do you think it's a viable concept in the future?
I'm so enthusiastic about the stuff that you guys are talking about. So, Sanjay, let me answer your question by talking a little bit about the hospital at home, right? So right now we send a nurse, we send a monitor, and then we hope the Wi-Fi works, and nothing really is ready for prime time. As we're starting to monitor the things that David's talking about with chemistries in the urine, as we talk about mirrors monitoring things, or being able to do things like structured vitals, detecting your movements, your gait, if you got off the couch more times day 1 versus day 2 versus day 3, those are indicators that these giant pattern recognizers will be able to apply. After you've got that corpus of data, you can build a system called a digital twin that will predict how you would behave under similar circumstances. And Sanjay, you and I have talked about the bridges that we build or the skyscrapers in Manhattan. Those things are built on a computer first. They're stressed every which way. 80-mile-an-hour winds, earthquakes, those sorts of things. We can do the same thing, saying, what happens if I give an AUC of 5 of carbo to a patient with this creatinine? What happens if I give a patient Enhertu right now, given the way that she looks, the way she feels, with her ECOG performance status of 2.25? And you can run that theory in hundreds of thousands of simulations to predict what's likeliest to happen, statistically speaking. And we do it right now. Every time you play fantasy football, right? You see that, pick your player, right? For me, Joe Burrow is supposed to get 26.75 points. They don't just guess that. On EA Sports, they run that simulation 100,000 times with his person in a video game to give you that score. 5 years from now, 8 years from now, we'll be doing that with all of our health data. So the rings that you're wearing, David, you will have that baseline. And it's not that far away. This isn't science fiction anymore, guys. This is actually arriving soon.
I totally agree. The whole thing about digital twins is right now when we choose a therapy, it's because of pooled data from populations for, this population of people with this diagnosis, this is the right chemotherapy to use. Does that really work in that individual patient? And so we're going to get to the personalized medicine with the predictions exactly as you described. I'm super excited about that.
One question I have for all of you, maybe Sam, we'll start with you first. What question should we be asking about this kind of technology in general that we're not yet asking?
I think the question that you should ask is, what is the signal that you want to focus on? Rather than just boiling the ocean, where are you going to get the biggest bang from the? If you want movement, if you want to focus, then focus on movement. What we've seen and what's been shown in diabetics is sometimes you can get a lot from one signal that has less noise. Rather than a million different signals, you're trying to do 10 million different things, and you get all of these pieces. But if you have the signal drives the data and drives the AI that Doug and David are talking about in terms of this precision. And it's all about getting the quality of the data that you're getting matched with the patient EMR. That is where the power comes from. So if you have all these different signals, but they're not telling you anything because the signals aren't very strong and they're noisy, and even if you're matching them with the data, it's not, you can't make anything of it. So these devices are as good as the signals that they're providing and our ability to drive data to them alongside them. So in order to scale this, I think what's exciting in whether it's oncology or so forth, is let's be picky and choosy about what we're doing and try to get something accomplished. Let's try to put our stake in the water and get something accomplished rather than trying to do everything. Because what seems to be scaring providers right now is many want to do everything, but then the thought of trying to do everything is overwhelming. And so our proposition to them is just try to do one thing really well, whether you want to do movement, whether you want to do temperature, heart rate, put a stake in the ground and do something rather than nothing.
So those that don't know it, they probably know it now. Sam has a colorful history in politics and very successfully. So I saw a little bit there where I was like, now I see why people drummed up behind her so easily. That was impactful. Doug or David, what's one thing that y'all believe that we should be asking about this kind of technology?
I'll give a very practical application to this technology. I happen to have an 85-year-old father who loves his temp shield, right? I think the possibilities for elder care are almost limitless. And if for the aging population, America is getting older, a lot of the world population is getting older, the cost of nursing home care is unbelievably expensive. And so if we could stave off nursing home care for 1, 2, 3, 5 years, a decade or something with different sensor technologies, some of them may be wearables, some may be activity sensors, some may be, is the stove on, is the water running, is the refrigerator shut? If we have information like that, we can intervene and keep somebody independent longer. That's a huge use case for this type of technology. And that's, that would save money, that would pay for itself. And so I think the applications for individualized health optimization are there. And we're going to see just kind of an explosion of these technologies in the future. I think the really quick use case for it is for the elder care.
Sanjay, I'd say, what if the patients don't want to know?
Ooh,
Yeah,
that's a good one.
It's a thing, right? So not everybody wants to know all of this stuff. Some people find it anxiety provoking. I think we probably have to leave it in their hands, just like we do other shared decision-making things for patient beneficence and independence and autonomy. You may not want to know if you have circulating tumor in your blood. Right? You may not want to know if you're going to have a heart attack in 2 months. Some people don't. We have a lot of people who don't want to know if they have colonoscopy, if they have colon polyps on colonoscopy, and they avoid those because they don't want to deal with the outcome. So I think part of that is who's going to be responsible for acting on the data. It seems common sense, but all of us are medical. All of us have post-college graduate degrees, and we live with this every day. But imagine if you're home alone, and you're terrified about some piece of data that you can't contextualize, you don't understand. Maybe your insurance company now won't insure you because of it. Maybe you can't get a job because they're predicting that you're going to have a very expensive disability soon, and it affects your hiring. We just don't know where this is going to go. And so sometimes I think we are drowning in data. I like Sam's idea of focusing. I really like the idea of validating things on clinical trials so that we can measure the impacts of these tools rather than the commercially available views. Unfortunately, it's much easier to get to the commercial audience right now than it is the medical audience. So I don't know. I guess I would say let's also buyer beware. Sometimes all data should not be measured, and not everybody's able to understand the context within which they've been measured.
That is such a good answer. I guess in part to the point about like my sleep habits, going a step further, there are things that can assess, by my own analysis, pretty darn well dementia and Alzheimer's, et cetera. Because when we're doing these like mini scores in clinic, it's for activities just, over the course of that 30 minutes to 60 minutes. But you're talking about things that can observe shuffling of gait or how long it takes to release the clasp of a hand on a doorknob. All of these things, and, even the pauses between answering, or how long it takes you to answer something that otherwise that exact moment 3 months ago or 9 months ago you were able to answer faster consistently. These are the kind of things that can actually be very good at detecting dementia and Alzheimer's. But then the question is, if it's not, if there's nothing you could do about it, then all of a sudden it becomes scary. I think my answer would be a little similar, but also tangential. And this comes from Bertland Mesco, who I had on my podcast about 2 months ago. And it goes to the concept of being a futurist or trying to be, and to be the best prepared one, asking, how can we be wrong or incorrect? And I think that's also very important, which just means that, yes, we could even get maybe 98.5, 2 standard deviations of the people where it's applicable to, but it's very easy to lose sight of the tails of either end of that. So the people that may get chemotherapy stop prematurely because everything about their sensors on their walking axis in their souls may suggest that they're going to get into a bad toxicity, and it's just wrong. They're not going to get permanent neuropathy. Or the people that again, the dementia score, say it tells you it's going to be coming, and they want to know, and then all of a sudden it doesn't, and how debilitating that can be. And so it really raises this question of, right now, these things are bells and whistles. It feels like it won't be at one point, but right now we have the liberty of these being things that we are pursuing or considering to pursue, outside of Sam's temperature monitoring, which, as a specific use case, an indication, to her point, distill it down to a use case. But the things that are not the use cases, I just don't know if our expectation expectation should be much higher before we go down these roads. Not knowing or being able to say that there aren't certain percentages that are just going to be told the incorrect information, because that takes diligence to clean up the other 2%. So I don't know. Would love to know anyone listening, their thoughts. You can comment, you can jump in. I know we already have committed to ourselves an episode on digital twins from these conversations, on maybe more of the regulatory stuff. There was another one that I cannot recall, but there's so many good conversations that come out of here. Is there anything else that you all want to share that you get excited about, or you want to send some cautionary thoughts or anything as it relates to longitudinal continuous testing, either in the hands of DTC, direct to consumer, or by providers, or for health systems for that matter?
I think it points to the importance of psychological health. Years ago, when MRD was first kind of being discovered and people knew about circulating DNA, they said, we're going to find things really early. And some doctors kind of raised the caution flag, just because we're going to have, circulating tumor DNA in somebody that's never going to develop a cancer. It's part of the immune system. And we're going to have this whole class of worried well. And worried well is a real issue. We see people that read their charts, very in a very detailed manner, and are concerned about the intonation of different words. And so, when the amount of data gets unleashed on the population, we have a different perspective. We've been in the field, worked in it for multiple decades. Sometimes they may be seeing it for the first time, and it may be of concern when they Google it and find out, oh, this could point to this scary event that could occur. And so figuring out how to navigate that and psychologically support people when this information is coming out is going to be important into the future.
I guess I would say, building on all of your points, and where I'm focused and where AION Biosystems is most focused is in cancer care. And there is a plethora, there is no end in terms of the data in oncology. What they need is actionable data, earlier data, to be able to intervene early. And so I think that's where we're going to make the great impact with wearables, is that identifying the signals where you can intervene earlier and also at the right time, and providing the tools in such a way that it's seamless for the healthcare system to ingest them, because that is the critical point, that they can come in, everyone's overworked and overloaded. We can bring in these tools in a way that is going to be welcomed not only by the patients, by the nurses, by the clinicians, the providers as well.
Yeah, I worry a little bit about our teams. They're stressed right now, and this is going to be all new. And from moving from this episodic data where we're collecting data to patients coming with continuous data, and we're going to be more like almost medical translators to find context within that, to say, what does this pattern mean? When can we ignore this noise? Because it's obviously scary to find that your heart rate dipped or something, and the doctor's going to have to explain that in a reassuring way. Which alerts matter, to go back to Sam's original context around signal and noise. But how do we move our workforce to stream-based workflows instead of just having this visit-based workflows? Because now we're already overwhelmed with the data that we have. We don't have enough staff. And now we're going to be handing them deluges of data, continuous monitoring, and I don't know who is responsible for acting on that right now, and so I will tell you, I think a lot of it's going to be AI. No big surprise there coming from me. But again, I'm not sure that our teams are ready for that either. And so there's going to have to be as much change management around this. We just wanted to get these tools in front of you guys. And we're going to do this all year on this podcast to let you see real world applications of practical solutions to our problems. Sam just happened to be the sacrificial lamb for the first one that we're doing, but there's more to come. We'll have to bring them along. That's why we have podcasts and education platforms like this. That's why we're building our websites and web platforms around these things, so people can gain a familiarity with the tools from hopefully people that they trust, that are a couple of years ahead in the tech world or the AI world or the wearables world, and maybe get curious enough to experiment on their own.
There is something, to be said about betting in the potential of something that helps save things, and so that's amazing. And Doug, I think you said that beautifully. If I had to make one big bet or a hot take, mine is that we're going to go from a day, the real winners are going to be the ones that don't just have the wearables, but actually come with an agentic workflow that helps you actually triage and know what to do algorithmically from it. I think we're going to see these little package deals in the future. This is probably years down the line, whereas this is the wearable, this is the agentic workspace that will actually triage this, that, and the other and deliver those insights and what to do with your staff members, much in the way that, a lot of the clinical trial competing space for these companies are like, well, we have a nurse navigator for you, or navigation. They have to come with something to not further burden. Let's talk about where it's worked. In summary, it's working in this infection management. We've seen that TempShield has data. It's also worked in heart failure. There are statistics that show about 23 to 53% reduction in hospital readmissions for heart failure patients. There's, I believe, $10,000 a year per heart failure patient that's saved by having things that detect sooner than later. 5,000 roughly for diabetes patients. And one thing that people don't think about enough is maternal health. There's reports of up to 50% of hospitalizations due to hypertension in pregnant patients when it comes to rural Medicaid patients, because we know that these syndromes during pregnancy are a very big thing. And again, these tip-offs are happening. What are some of the things they need to change? Alert fatigue, or making sure that alert fatigue is not a thing. How do you have the interoperability? What do you do with the data? How do you have compliance be preserved, which Sam sounds like an expert on that compared to most wearables historically, and not just saying that, as well as digital literacy, in addition to the medical literacy. So there's two kinds of literacy when it comes to these wearables. Does the patient know? Does the provider know, et cetera? So a lot ahead of us, and I'm sure this conversation looks a lot different a year from now, but I want to thank all of you for coming, the listeners for listening, especially if you've made it this far. You're clearly interested in innovation, and that's what we plan on bringing you from Tensor Black, from this podcast, AI in Healthcare. We also have new information. We also have news bites and information on our website where you can get these articles that are in enterprise to personal life to oncology in different categories, and they rotate at least weekly. So we hope to learn together, and we appreciate you listening.